Hi everyone for sparing your time to us at this time of the day. Today we will be talking about the neurological diseases and states in pediatric population. So pediatry has many fields and there are many consultants. Therefore, I'll be talking about the mostly referred diseases and comorbidities seen among the pediatric population. First of all, CLP is an evaluation of the psychiatric problems among children who have psychiatric or neurologic problems. CLP requires an holistic perspective for the child, both physically and psychologically. In neurological diseases, early diagnosis and treatment are important. Early psychiatric symptoms may be ignored, and CLP helps us to diagnose those symptoms. And also, psychiatric symptoms are sometimes the first signs of a neurological disease, and they may cause wrong diagnosis. CLP minimizes that possibility. And sometimes the psychiatric disorders may negatively affect the loyalty to the treatments. Therefore, psychiatrists may develop strategies to make the children and their parents obey the treatment strategy. And families and children are made more aware of the treatment and their mood through some trainings, and psychiatric support is of vital importance to manage crisis situations. Epilepsy is one of the most common neurological diseases among pediatrics population. An important part of the children diagnosed with epilepsy face minimum one psychiatric disorder, and CLP is critical in early diagnosis and management of the depression anxiety of children with epilepsy. Epilepsy prevalence is around 3 in 1,000 in developed countries. In 1981, epilepsy patients were found, Rutter reported that the psychiatric disorder with epilepsy children was around 30%, and also psychiatric disorders was around 21 to 60% among the children with epilepsy. And most frequently seen psychiatric disorder is depression. In an adolescent study, 156 epilepsy patients were applied key sets, and major depressive disorder was found in 28% of them. And depression was found to be correlated with the weak treatment compliance. In another study made in the US, depression or anxiety was found in 1 out of 4 children. Regarding the depression in epilepsy patients, there are many risk factors. In psychosocial terms, stigmatization, stress, negative family attitudes can be among these factors. In terms of neurobiology, empirical animal studies show that epilepsy increase the tendency towards depression, and depression increase the tendency toward epilepsy. There is a bilateral relation, and it is caused by the disorder in the serotonin transmission, and it's a marker now. And also, epilepsy is course is accelerated with the high corticosteroid levels. Again, high glutamate levels can also trigger the epileptogenic process, and at the same time, serum and blood brain brain spine fluids BSF also in BSF high glutamate levels were indicated. And depression, how it is represented in epilepsy: perictal depression, dysphoric emotion state generally seen after the seizures. And ictal depression symptoms are anhedonia, feeling guilty, and suicidal thoughts during the partial seizures. And interictal period depression is generally causing irritability, being stubborn, and aggression. Antiepileptic medication may cause depressive symptoms. These are called iatrogenic, especially antiepileptics with a GABA activity like pyrimidine, benzodiazepine may cause more depressive symptoms. This risk is higher among the patients who have depression history. And the medication SSRI are the primary option for the children with epilepsy due to their side effect profiles, and SSRI medications may interact with antiepileptics. Antiepileptics like phenytoin, carbamazepine, phenobarbital, pyrimidine are subscribed in normal doses, and over 300 milligrams. Sopiramate causes enzyme induction in the liver. Therefore, they may cause the destruction of antidepressants. And also, antidepressants increase the antiepileptics in the blood level. For the epilepsy patients who have bipolar disorder, as antiepileptic, lamotrigine is recommended. Epileptogenic side effects. Due to these, lithium shall be avoided. For bipolar disorder and epilepsy patients, if antidepressant is necessary, they must be used together with the emotion mode regulators. And it's one of the psychiatric disorders at the second rank, and its prevalence, anxiety disorder prevalence, is around 15 to 25%. There are many risk factors for the epilepsy patients, like not predicting the seizures, fear of that, not controlling the seizures, stigmatization, lack of information regarding epilepsy, and anxiety presentation in epilepsy is seen as an ictal psychiatric symptom. The simple partial seizure or complex partial seizure during this, as the first symptom, it may occur, and in ictal panic attacks, generally they last for 30 seconds. There is fear, tachycardia, and dyspnea-like autonomic symptoms can also be seen. When we look at the subtypes of anxiety disorders, phobia, separation anxiety, social phobia, common anxiety disorder, and other anxiety disorders are seen. For these patients, SSRI groups are effective. However, benzodiazepine can also be tried for a short time until its effects are seen. Psychoeducation is also a key point. Depression and anxiety. For the children with depression and anxiety, psychotherapy may also be recommended. In epilepsy, psychosis is rarely seen, but it's a serious comorbidity. Psychosis risk may change for the severity of the seizure, and between the epilepsy and psychosis, there is a bidirectional relation. The prevalence in epilepsy, the psychosis prevalence in epilepsy is around 5.6%. During the pediatric age, hallucinations or formal thinking disorders and negative are seen frequently, but negative symptoms are rarely seen in epileptic psychosis. Clinically, epilepsy psychosis starts hours before a seizure, and there may be some different symptoms like derealization, depersonalization, forced thinking, ideomotor, déjà vu, je me vu, anxiety, euphoria, hallucinations, or delusions. These generally end with the delusion and with the seizure. And in ictal psychosis, generally, these are non-convulsive status epilepticus episodes, seizures, and during a seizure, generally, paranoid thoughts, depersonalization, derealization symptoms are seen. For post-ictal psychosis, as one of the frequently seen perictal psychosis in epileptic psychotic disorders, and it lasts for 1 to 6 days. Abnormal mood, depressive or manic, and paranoid delusions are seen. Mystical experiences with religious content and a high ego or aggressive behaviors or suicidal attempts are reported. Generally, they remit within days or weeks. It doesn't require long-term antipsychotic treatment, but it may also progress towards a clinical psychosis. Normalization. Alternative psychosis is not related to the seizures. In typical psychosis, there is no relation between the psychosis and timeline. It is seen in 10% of the temporal lobe epilepsy patients, and some starts after the age of 25, some starts earlier. It is defined as the schizophrenia-like psychosis in epilepsy. And when compared to schizophrenia, there is a more effect and a less distortion of the personality in psychosis. And for the treatment, psychoeducation comes in psychosis with epilepsy. The main treatment is controlling the seizures. Generally, antipsychotic medication is prescribed for a short term during the acute phase, and it also perirectal psychosis. It can be used for longer terms. And antipsychotics out of zotapine and clozapine may be tolerated among the pediatric population. Just case presentations were available. However, as a general principle, antipsychotics may be prescribed at lower doses first and then increased. For epilepsy patients compared to the normal population, there's an increased DHB level. Again, many studies show that patients with epilepsy, the prevalence of DEHP is indicated to be 12 to 39% compared to the healthy groups. The DEHP ratio is 2.5 to 5.5 times higher compared to the other children. And in a study, these children were compared to healthy controls, and it was shown that comorbid concentration loss prevalence was higher among children with epilepsy. And what are the risk factors for concentration loss in epilepsy? The genetic tendencies, central nervous system, serious seizures, frequent epileptiform discharges, anti-epileptic medication side effects can be considered among the risk factors. In many studies, the concentration loss, which is seen in normal population, have some subtypes, and as the side effects of the anti-epileptics, we see that cognitive insufficiency may cause this concentration loss. Therefore, a good history must be taken for those patients. How to treat the epilepsy patients then? For the patients, for the children with epilepsy, the concentration loss treatment may be just like prescribed for the normal population. And for the adolescents and pediatric population, The threshold for the seizure must be taken into consideration while prescribing the anti-epileptics, and also it doesn't affect the other medication that is prescribed. In addition to epilepsy, when we see concentration, the response to methylphenidate was around 60 to 70%, which is less compared to the normal population, and most probably among epilepsy patients after the concentration loss treatment, the seizures the seizures increased twice and compared to the before treatment, pre-treatment. Now let's talk about some juvenile Huntington disease, which is movement disorders. It's a neurodegenerative disease which starts before the age of 21 and is characterized with motor, cognitive, and psychiatric symptoms. The severity, dystonia, and seizures are more common, and the executive functional disorders and less school performance can be among the cognitive changes. In a study conducted, 31% of these patients referred for some psychiatric symptoms, mostly depression, and generally symptomatic treatment is given for these patients. Their life quality is increased with this. And for the movement disorders, haloperidol, pimozid-like medication, and physical treatment can be administered for these patients. Also, olanzapine is also stated to be beneficial in some studies. Siraram Kore is also a major complication of ARA, and this neurological disorder is characterized by involuntary and rapid movements involving the face and extremities, and obsessive compulsive disorder is the most researched, therefore reported neuropsychiatric symptom in South and Homs, Korea in children. In two studies, it was shown that 70 to 80% of children with SC had OCD symptoms. In a study investigating the prevalence of ADHD in these patients, ADHD comorbidity was found at high rate of 60% in these patients with persistent SC. SC is usually a mild and self-limiting disorder. Treatment is usually required carbamazepine. Tuberous sclerosis is an autosomal dominant genetic disorder characterized by well-circumscribed, histologically benign lesions. Genetic studies show that mutation in the TSC1 gene on chromosome 9 cause this disease. As a result of this mutation, mutations are seen. Among the most common psychiatric disorders, autism spectrum disorder is seen up to 40 to 50%, ADHD in 30 to 50% of TS patients. TS is considered to be the medical disorder with the strongest demonstrated association with ACD. The relationship between ASD and TS is known to be bidirectional relationship, and it's said that these rates of TS in ASD patients are 200 to 300 times higher than the general population.
There is no proven effective psychopharmacological or psychological treatment for TAND. Early diagnosis and treatment programs are recommended for ASD and psychosocial and psychopharmacological treatments for ADHD. Recently, Pathophysiology of TS. Improvements in memory, recall, and executive skills were reported in 5 of the individuals who received the TLR inhibitor treatment, which was found to be promising. Multiple sclerosis. It's a neurodegenerative illness. In adults, children under 16 years of age are thought to make up 2 to 5% of the total MS population. In adults, physical symptoms such as sensory motor impairment, optic nerve, bladder, and bowel dysfunction are more common, whereas in the pediatric population, these physical symptoms are less common, and cognitive problems such as decreased attention, language, memory, and visual motor function are more prominent. In a study, 25 of 45 children with MS with a mean age of 15.3 years had at least one psychiatric comorbidity, and 17 of these 25 patients had at least 2 psychiatric comorbidities. In this study, the most common psychiatric comorbidities in children with MS were anxiety disorders, depression, and ADHD. Fatigue in children with MS has been reported to be as high as 40% and has been shown to be associated with physical emotional difficulties, sleep problems, and reduced quality of life. Regarding psychiatric problems of MS patients, children, treatments is not sufficient, and in general, in MS patients, depression treatment adopts psychotherapeutical approaches and psychopharmacological combinations. In adolescents, SSRI and tricyclical antidepressant treatments resulted in positive results. Thank you very much for listening to me.